Hello, I'm Nora Hanna, Chief Engagement Officer at Sun Health, and I'd like to welcome you to this episode of Coffee Connections. We created this series to help you stay connected to the latest developments in healthcare and wellness by hearing directly from experts in our community. The Sun Health Foundation is committed to ensuring that this region has access to the most recent medical and technological advancements, and that we attract the brightest and best practitioners for care. To that end, we are the exclusive philanthropic partner to Banner Boswell and Banner Del E. Webb Medical Centers. Our mission is to empower others to live longer, healthier, and more purposeful lives. So we're excited to be able to offer you this unique access to these valuable expert resources. Thank you for joining us and enjoy the presentation. And for those of you who don't live in the Colonnade, welcome. It's so beautiful here. This is one of 4 life plan communities that Sun Health owns and operates. And in addition to all these wonderful, places to live, we also have a couple of other products, including Sun Health at Home, which is an opportunity for you to get all the benefits of a Sun Health community, but in your own home. And that could be a home within Sun Health or a private residence somewhere else. So we really like to find ways between all the work we do within the community to make Sun Health your home. And in some respects, our speaker today is really going to play into that, because we're really about having this be, in some respects, your healthcare home as well. We have access to a lot of resources and partnerships. I love to tell this story, and I apologize for all of you who have heard me tell it so many times before, but I'm really so proud of the history of Sun Health. We were really born out of volunteerism. Residents came to live in Sun City in 1960, which was the year my family moved to Arizona from Long Island. And Sun City was just opening then. Del Webb, January 1st, 1960. That was a big day. But within a few years, it was very clear that the community did not have access to acute health care. You couldn't get an ambulance to take you to Youngtown or to downtown Phoenix. And so the citizens got together and said, we're gonna fix this, darn it. And I just have this impression of them sitting around a kitchen table saying, you know what we need? We need a hospital. Let's build one, which I love the ambition of all that. And of course, it was a generation of just sort of getting things done with community resources. It's kind of something that doesn't exist in the same way today, I don't think, but I'm hoping we come back to that in terms of community engagement. Anyway, they raised money, went door to door, and built the Boswell Hospital, which they opened, later in, I think, 1970. But they were very successful in this, and subsequently built Del Webb Hospital right across the street from us here. And even more importantly, and this is how it really plays into Dr. Benoit, after we've resolved acute care, the question is, how do we keep going into acute care? Like, what can we do to stay healthy longer and not have to take advantage of that kind of resource? No one wants to be in an emergency room. And what Sun Health did was they founded the Sun Health Research Institute 40 years ago this year. So think about that. So we've really been on the vanguard of preventive health. What can we do to deal with the diseases of the brain like Parkinson's and dementia and things like that, so that we could prevent them as we move forward? And so I think a lot of what we care about at Sun Health is ensuring that everyone in the community, whether you live or are a member of Sun Health or you live in our community, that we give you access to those resources to help you stay healthier, more active, more purposeful for longer. And that is really at the heart of our mission. So think about that as we move through today. We have more speakers like we'll hear from today coming up. And this will be the last one for the summer. Who's leaving this summer? Anyone? Yeah, a couple of hands went up. They probably don't, probably feeling, are you feeling guilty about that? No, not at all, not at all. Yeah, I'm stuck here for the summer. And even after these many years in Arizona, the heat still gets to me. So, but coming up in the fall, we'll have more coffee connections, more ways to engage, and then we have our Live Well conference, which again, really plays into all of this. The conference the first one was last year, and this year is going to prove to be just as great. November 20th is the day you want to make sure you hold on your calendar. We have both dates available, and we're deciding whether we will have events on both days. But it will be filled with speakers and information around how you can work on your own health, preventive care, whether it is your cognitive health, your physical health, or your social and emotional health. And that is proving to be one of the biggest factors in healthy longevity, is social connection, like being in a room like this today. So it's really critically important, and you'll come away from that with amazing resources. So a little bit about Dr. Benoit. He's a Canadian. Are you also a US? Are you both? Yeah, are you going back to Canada this summer?
Yes.
Yes, he is, but you're not for the whole summer.
No.
Ah, thank goodness, because we need you here. I love the subject of this, of sort of how do you avoid surgery? How can you keep your joints and everything healthier longer? He's dedicated to providing high quality, compassionate care. And I love this part, specializes in helping patients restore mobility and reduce pain through personalized treatment. I don't know about the rest of you, but joint pain is something that is very serious in my life, and I'm all about ways to prevent it. He earned his medical degree from Laval University and completed both his residency and fellowship in orthopedic surgery at Université de Montréal. How did I do? Pamal. He is affiliated with Banner Del Webb, and we have a long-standing relationship with the hospitals. We transferred them and merged into the Banner network in 2008, and that was really a terrific move. We just heard from the CEO of the hospitals yesterday in their annual report that Boswell and Webb are number 1 and number 2 in emergency room care in the whole Banner network. So we have some, thank you. I agree, Mary Lou. It's a big deal to us. Outside of his practice, Dr. Benoit enjoys spending time with his family, staying active through weight training, skiing, hiking, biking, and fishing. I do all of those but the fishing, so we have a lot in common. And with that, I'd like to welcome Dr. Benoit. I like to fish, I'm just not that good at it.
A lot of it is luck. Thank you so much.
There's this, and here's how you advance your slides.
Great. Thank you very much.
You bet.
Good morning, everyone. I recognize a lot of faces and scars. So thank you. Thanks for having me here. I really appreciate spending time with you and sharing. Thank you. I appreciate sharing what I know, what I do, and how I can help patients and people stay active. So a little bit more about me. Yes, I am originally Canadian from Montreal. The French-Canadian accent never goes away, even if I've lived in the United States for 25 years now. I've been in practice for 28 years already. I went back, I was a general orthopedic surgeon, so I saw sometimes on my bio that it talks about me doing carpal tunnel surgery and rotator cuff repairs. Please don't make an appointment with me to do that. I went back and specialized in joint replacements after 11 years of practice, and that's all I've been doing since then. So I specialize in hip, knees, and shoulder replacements, and I do a lot of revisions. We might talk about that later a little bit. So in joint replacements, there are what we call primary joint replacements, which is the joint you have when other treatments have not worked. And there are revision joint replacements when unfortunately there's failure of that replacement, either from an injury or wear and tear or other problems that might arise. So I was asked to come and chat this morning over coffee about treatment of osteoarthritis and also trying to figure out how to time how to do with the timing of a knee or a hip or a shoulder replacement. So do we do it early? Do we do it late? And I have that question all the time in my clinic. Before I start, I want to tell you I have a wonderful little family. My wife and I have been married 33 years. We just celebrated a couple of days ago. And we have two wonderful kids. They're no longer kids, but they are. One is turning 28 years old and he lives in Oregon. He practices law over there. And I have a daughter who is in medical school actually, who hopefully will do similar things that her father does. So anyway, on this I'll move forward and please interrupt me if you can't hear me or if urgent questions. Otherwise, at the end, I definitely will be open to ask questions. So joint replacement surgery, when do we do that? So early or later, earlier or later? And that's a common question that people have. I'll be honest with you. Every day I'm in the clinic, I tell some patients, don't do it. You're not ready. You know, there are treatments that can be done for osteoarthritis or joint pain that are much less invasive and somewhat dangerous than joint replacement surgery. I had a phenomenal senior associate who worked with me when I started here. Some of you might have known him, Dr. Forster. And Tom Forster always said to patients in the clinic, because we did a lot of clinics together, I remember him putting his hand on someone's leg and saying, "You'll know when it's time. Okay? It's not the surgeon who should know that." And I think that's very important. Osteoarthritis treatment, OA for osteoarthritis. So first of all, conservative treatment. Okay, when we hurt, we all start with that. Don't need a doctor for that, okay? We start with simple things. Over-the-counter medication, NSAIDs. Someone asked me about those NSAIDs this morning. They can be helpful, but it can also be harmful. So taking them too long is probably not recommended for most of us. It can affect your kidneys. It can affect your stomach, cause a bleeding ulcer. Various things can happen. Physical therapy can help. Someone asked me also in the crowd this morning, and yes, definitely, physical therapy helps, restoring range of motion and helping with inflammation. The therapists are very good, and they can help us avoid surgery and relieve the pain and keep us mobile. Weight loss, big topic these days, okay? So carrying too much weight is definitely a little bit detrimental for knees and hips. And there are many ways to help patients lose weight. Supplements, there's a variety of supplements, and I'm sure many of you take those. It's all over the place, to be honest. And what I tell my patients about various supplements is that they're not dangerous. Okay, I say, yes, if you want to try something, definitely give it a try. Most people who come to me have tried glucosamine and turmeric and other things, but it doesn't always work. So when it doesn't work, that's when you want to see an orthopedic surgeon. Exercise. I talked to a lot of people this morning who are playing pickleball and exercising and walking. That also helps relieve pain, surprisingly, until it does not. Sometimes, you're trying to play pickleball, but your knee or your shoulder hurts too much. But then you can go to the gym, you can work out a little bit, and your brain releases some endorphins, which are substances that the human body can produce to help reduce pain. Other treatments, I'm sure you can think of other treatments, some red light therapy and various things that keep coming, it seems like every few years. And then there are more invasive treatments. When those simple things don't work, okay, that we talked about, then the surgeon, typically your orthopedic surgeon or your primary care or the rheumatologist, might decide to look at injections. okay, for the knee, the hip, or the shoulder. I listed 4 varieties of medications in terms of reports. Cortisone has been utilized for a long time. It comes in forms of different brands, Depomedrol or Canalot, and it helps. The problem with cortisone injections, one of the main problems is that it does not last. Okay? Typically, if you have inflammation in your knee, the knee is swollen and acutely painful, then to do cortisone injection will help. But I tell my patients, your pain's gonna come back within a few months, 2, 3, 4, 6 months. Hyaluronic acid, commonly known as gel injections. Okay? People have those. They have existed for a long time. I've injected hyaluronic acid in knees for 25 years. Some doctors do it also in other joints, but in the United States, it is approved only for knees. Yeah. It's not that it's dangerous. I actually injected hips with hyaluronic acid in Canada, but here the doctor, if you do that, will have you sign a release. PRP for platelet-rich plasma and stem cells are relatively similar procedures. You go to the doctor's office and they get some blood sample and we spin it out. I don't do those, but we have doctors who do those, and extract stem cells or platelets and inject that in joints. There's no guarantee of success with any of that, okay? And a lot of patients want to try that. It's important to know that the first 2 are typically approved by insurances. The PRP and the stem cells oftentimes are not covered by insurances. It is an expense. When all that does not work, I've seen people with scars, joint replacement surgery becomes an option. Now be aware, joint replacements in the form that we know it has not existed for a long time. In the mid-70s, prior to that, there was no such thing as knee replacement, shoulder replacements, hip replacements. Joint replacements by the numbers, a few numbers that are interesting. Total knee, TKR, 1 million per year in the United States and growing. Why? Because the population grows. The population ages and people want to be active. Okay? I see people playing baseball and softball, pickleball, which was not possible in the past if someone had severe painful arthritis. Total hip replacement. Those are numbers from 2024, about 700,000 a year, a little less than knees. Shoulder replacements, okay? Total shoulder replacements or reverse shoulders. People might have questions about that. About $250,000 per year and climbing. Again, those things are available. I'm sorry, this is relatively small, but it shows the needs, okay? Some projections and this is the American Academy of Orthopedic Surgeons, a very reliable source. We're expecting 3.5 million total knees in 2030. It's right around the corner. Something like half of Americans develop knee arthritis at one point. Knee replacements last a long time, more than 20 years. I just had that discussion also with someone. So those are procedures that are there to help, and they are available. Thankfully, most of the time they do very well. Thankfully also, the industry has improved the outcomes of joint replacements in many ways. Now, I was asked specifically, finally getting to this, indications to proceed early. Okay, is there a time when you see a surgeon, you come to the office and the surgeon will say, we need to do it. Okay, that's important. At first, we start with what I said. We start with simple measures before coming to the office. There are 3 reasons to have surgery right away. It's a no-brainer. Someone has a fractured hip, needs a hip replacement. We don't discuss that. People are happy to do it. There's no hesitation. A dislocation, an infection in the joint, those things are emergent, and typically there's not much discussion. You come to the ER and it has to be fixed. Here's a dislocation, not a good day in the office for anyone. It's fixable, but no one argues that this is urgent. Safety reasons. Okay, we're talking about reasons to do surgery when other things don't work. I would say every week I hear about, every day actually, patients falling because of bad knees and having a hip fracture. You see that. Someone trips because they're leg pain. And my partners who do trauma will send patients back to me after they treated them for their hips so that I can do their knee replacement. So oftentimes it ends up with 2 surgeries. Fall risks are to be considered. What are the falls risks? The risk of falling? Well, just aging is a risk. Losing mobility is a risk. Having neuropathy, not feeling our feet, rugs in the house, so all sorts of things that can be assessed and decrease the risk of falls over time. The vast majority of us want to do joint replacement for this reason. It's called quality of life. And we all have different ideas on what quality of life is. But we certainly know and agree, all of us, that being in agonizing pain affects quality of life. When someone hurts, most of you have had pain at a different degree in your life, and I've had to. And it takes all your focus. All of a sudden, the rest of life is not as enjoyable. I see someone with an arm sling who probably had some surgery or an injury there. It's not fun, and it's hard to enjoy life because you have a hard time sleeping, bathing, different things. So here's someone who needed a hip replacement years after having surgery. Fix the hip, move on, and after a few months, playing pickleball or golfing and enjoying life, not thinking about pain, not taking pain medication. Here's a shoulder, someone with a bad shoulder, arthritis. Well, doctor, I really can't play golf, or I can't throw a ball, or I can't lift anything at the gym. I have a hard time sleeping. A shoulder replacement fixes that. It's important. I always tell my patients this is not the work of God. Okay, this is the work of a surgeon. Okay, I can take knees like this, that are bone on bone, both knees, and give knee replacements to patients, sometimes both at the same time like this. And it's very successful. It's also invasive. We make big scars. You wake up with the worst pain you ever had. But it's a commitment. Patients do their physical therapy. Patients use their walkers after surgery and move on with life. It's very rewarding. I can't imagine doing anything else as a career than what I've done for 28 years. I love it. Quality of life might mean traveling. Just simply walking your dog, okay? Enjoying life every day. It seems simple, but it's not. When you're hurt and every day, every step is painful, there's no fun. Well, it can be as demanding as playing pickleball. I'm not good at that, but I'm sure a lot of you are. And it seems fun. I've played a few times and it seems very fun. But if someone has a lot of pain, well, 1, it's unpleasant to move. 2, it's more risky to fall. So some people will just pull back from playing pickleball. Simple things, just shopping. Hey, going grocery shopping. It always surprises me when I hear people coming to me and say, Doc, I can't even go to the grocery store anymore. I hurt so much. It seems simple until you have a lot of pain and you just can't do it. Shopping cannot always be pleasant. I see that gentleman's face there. I loved it. So, gardening. Simple things, simple things of life that we want to do in our years of retirement. Enjoying grandkids, being able to sit down on the beach, not always easy to get back up. Driving, I'm sorry, this is certainly an English or a British picture because the driver is on the right side, or I inverted it, I don't know. But simple things, driving to see people, driving to go to the grocery store, to go shopping, to go to a movie. It's hard to get in and out of a car with a very bad hip. I hear that, and it's one of the first complaints. People say, I just can't get in and out of my car anymore. I hurt all the time. Playing golf. I don't know if you guys have a swing like this, I don't. But you know, playing golf is something that requires physical ability. And if there's pain or restriction of range of motion, it's difficult. Of course, we're never going to be that age again, but we can still walk, okay? And we can help with this. So in conclusion, before you ask questions or comments you might have on my presentation, joint replacement, it helps improve function. It decreases pain. I never promised a patient that there's going to be no pain. Okay, it's again the work of a surgeon, and we can't replicate what we had when we were born, but we can definitely be improved by joint replacements when it's time. Restoring movement, okay, stiffness, being able to go around, walking around the community here. Joint replacements are safe. Okay? There is a risk. Of course, there's a risk, so it's important to discuss that with your doctor, with your surgeon. And the experience of the surgeon is important. They are durable. Okay, I've seen drastic changes over 28 years of practice. Nowadays, I tell my patients that barring any immediate complication, anyone here can have, if you have a joint replacement, it will last a lifetime. Yesterday, I had a 37 and a 36-year-old patient. One had a hip replacement, the other one had a knee replacement that I had to do at a very young age, at very young ages. I told them, you know, I'm definitely going to be retired by the time you need revision, and the implants are so good, you might not even need that. But it's for now. It's, you know, they could not tolerate their pains and lack of function anymore. So this is something that changed. When I graduated years ago, if I had scheduled someone at 36 years old for a knee replacement, the chief of service would have canceled me, would have canceled my surgery. Optimization, which means, you know, making patients as stable and healthy as possible before surgery is important. Okay? The medical conditions, we want those at their best. We can't change the fact that we're diabetic. We can't change the fact that we have hypertension or coronary heart disease, but it can be stabilized. Okay? Monitoring the weight, monitoring the blood sugar is what we call also the A1C, which is a marker for glucose levels in diabetics. So all those things are very important before undergoing joint replacement surgery. Having a good health condition does not guarantee outcome, but it definitely minimizes the risk associated with surgery. Heart attack, infections, pneumonias. And unfortunately, those things sometimes happen. But if you go to surgery at your healthiest possible, you can't be 25 years old again. But if your doctor has made you optimize your medical condition, for most people it's very safe. I schedule people in their 90s every week. They have knee replacements and shoulder replacements and knee replacements. And I tell patients, what if you're going to live another, people come in and they say, am I too old for this? I'm 91 years old, I'm 92 years old, what am I going to do? What if you live 5 more years like this? You want to live with that type of pain? I don't think I would, be knowing that the surgery is safe. So that's a good reason to have surgery. Important to discuss that, I have to say that. Okay, when you meet with a surgeon, what are the pros, what are the cons? I also see patients who come to see me with joint replacements that have not done that well. And I think it's crucial to discuss with a surgeon. Am I ready for surgery? What are the pros? What are the cons? Everyone's different. What are the benefits of the surgery versus the risk? And with that, patients can make an informed decision. And if surgery is scheduled, it typically is very successful. So, please, questions or comments, I'm ready. Yes, that hand went first.
Yes, doctor. I had a knee replacement about 4 years ago, and he went up the center of my knee and cut that way and did the total replacement. And I understand now there are some approaches where you go in through the side of your knee. Can you explain the difference and why one is better or preferred over the other?
Sure. So what you're referring to is what came up a few years ago and publicized as Jiffy knee. Okay? And so what that is, so the incision, just to clarify that, and if any of you had it here, please feel free to chime in. So the incision is in the same location, okay, on the skin. It might be a little more medial, it's not lateral, so, but for the most part, in front of the knee. The length of the incision is similar. The difference is that instead of going and separating the fibers of what we call the quadriceps tendon. So the quadriceps, that big muscle here in front of the thigh, it ends with a tendon that connects to the kneecap, the patella. So your surgeon went in and split the fibers, did not cut anything, but separated the fibers to access your knee. It makes an easier approach to the knee, and outcomes between what you're referring to as Jiffy knee, or in medical orthopedic terms is called the subvastus approach. Outcomes are still being looked at. There's no evidence, scientific evidence of any difference. And surgeons who do those have to be trained at doing those very well, because a knee replacement like you have is typically very successful. It takes a bit of time to recuperate. So granted, I think I've heard some patients say, you know, I did faster, I recuperated a little faster, a little bit less pain with this. So I have an associate who does those. I have not switched because I have good success with my knee replacements, but the thing is, this is not a new approach, okay? So 20-some years ago, I used the subvastus approach, and I thought it was difficult to get in the knee. For some patients, it might be a little easier, and now they kind of brought it back on the market with a new marketing tool called Jiffy knee. But it's the same implants, same surgeons, typically, and in the approach you had, I want you to be aware that there was no muscle or tendons or ligaments cut. Okay, so that those are statements that I've heard said, oh, well, I heard I'm not gonna have my ligaments cut. Well, no one cuts ligaments during knee surgery. So it's a marketing tool, and it's being evaluated to compare with the approach that you had for you. Long answer.
I had a question about the materials for the new menu.
Sorry, I couldn't see you.
The joint materials, the replacement joint materials, is it titanium? Is it ceramics? Is it a combination thereof? Are there new advances? I mean, sometimes you hear about people that broke their replacement hip or whatever.
Good question. So implants typically are made of titanium. So there are multiple parts to a joint replacement. Okay? But the parts that are fixed to the bone, either it's in the hip or a knee or a shoulder, the parts that are fixed to the bone are made of titanium. Why titanium? Typically bone grows into titanium and makes it its own. So it becomes part of your body. Now the joint bearing surface has changed over the years, and the titanium has improved as well. The joint bearing surfaces are typically a smooth surface called polyethylene, and the hard part, okay, let's say the ball that fits on that socket for a hip or on a knee, is made of a harder surface, either metal or ceramic. And we went away, some of you, hopefully no one, but we went had one of those implants that was recalled, called metal on metal. So on hips at one point, in order to prevent wear, orthopedic surgeons started using metal balls on metal sockets with nothing in between. That was the joint. Well, sadly, it caused some fretting, if you want, and it turned into a disaster. So we need to learn from that. And at this moment, the implants are made of, for the most part, of a hard surface, either metal or ceramic, and the polyethylene, that's substance, the material that looks like plastic or Teflon. I was talking with a gentleman over there earlier. He was asking me about someone he knows. What wears out? So that plastic part, or the liner, that's the smooth surface in the joint, dates back to 56 years ago. And that's the part in the joint replacement that used to wear out. Just like shoes or tires on a wheel. And a brilliant scientist about 20 years ago, a group of scientists worked on how to make that substance, that material, more durable. And they figured out, God knows how, that given that a dose of radiation before it's packaged, before it's implanted, a specific dose of radiation, like in cancer, bonds the parts of that material together just fine, preventing it from wearing out and also preventing it from becoming brittle. In the early years, unfortunately, that process made the material brittle. Now we have it figured out, and they don't wear out anymore. That's why I tell my patient, yesterday I told them, you know what, they're 36 years old and 37, this implant will stay. New things coming up. Nickel allergy is an issue. Okay, and in the United States, there seems to be more and more people either allergic to nickel or aware of the nickel allergy. So some companies, most orthopedic companies, are working their way at producing implants that don't contain nickel because of the risk. I have redone a few joint replacements over the course of my career for patients who had nickel allergy, and it's very disheartening. Go ahead.
Why are they doing more reverse shoulder replacements than regular shoulder replacements?
Sorry, where? Oh, good. Okay, I'm sorry. I was looking over there. Sorry. Thanks. Good question. So, shoulder replacements have existed again almost as long as knees and hip replacements, 50 years. Before the arrival of reverse shoulders, also about 18, 20 years ago, we had no good treatment for people with arthritis and rotator cuff disease. Let's see, I tear my rotator cuff, and 15 years from now I need a shoulder replacement. That cannot be fixed with a regular shoulder replacement. So for years, decades, work was done on something called reverse shoulder. And I'm lucky enough that I know Dr. Mark Frankel, who is actually the grandfather of reverse shoulder replacements. I trained with him multiple times. And reverse shoulders are now representing 80% of shoulder replacements done in the country. So basically, most people who need shoulder replacements need a reverse because they have bad rotator cuff tendons. The second reason is we found out that it's much easier to recuperate from a reverse shoulder. So we as surgeons want to help our patients, and we do much more reverse shoulders, even sometimes if the rotator cuff is not that bad. After a certain age, 75, 80 years old, I'm tempted to do more reverse shoulders because the practicality of it is that people recuperate quicker. Thank you.
I had two jiffy knee replacements last year, 8 weeks apart. Can you hear me? Okay.
I can.
question. I had jiffy knee replacement, on both my knees last year, May and then July. And I'm still having pain now from the surgery. Now, I did all the physical therapy, which included, right away, I was cycling. I had a little stationary cycle in my apartment. You did it 5 times a day for 15 minutes, and that was the initial physical therapy, which seemed to work. But now I have scar tissue that hurts, and just overall some pain in the joints themselves. And some people have said, well, it takes over a year for you really to recover. And that's really my question: is it a year? Is it a year and a half? Am I stuck with this? What do I do?
So first of all, thanks for sharing with us. I think the first part of your statement is important, and I hope your surgeon told you, like I said, joint replacements are not natural, given to you at birth or by God. And they don't always feel totally normal. I hope, that's what I tell my patients when I'm going to give you a joint replacement, I hope you're greatly improved, and I hope that's the case for you. I think it's important to bring that up to your surgeon and the team of your surgeon to make sure that there's no complication or the loosening or something not doing well. But yeah, it can continue to hurt or be somewhat painful for over 1 year. So it's a long time. That's the part of joint replacements, mostly knees, that is a little frustrating sometimes. But I would encourage you, as long as there's no complication, your surgeon is satisfied with the way things look, to continue to exercise, go walking, do non-impact or low-impact exercises, go to the pool, bicycle, different things like this. But yeah, there's a percent of people who continue to have some pain. Hopefully it's not agony. Okay. Yes.
If you have torn meniscus, what's the difference in arthroscopic surgery as compared to knee replacement? And how long is the recovery period for that? Is it less than what a knee replacement would be?
Very good question. So arthroscopy, okay, which is a procedure where we go in with a small camera in your knee. A lot of us have had it for various reasons. It's used mostly for younger patients. Okay, someone who's 16, tears their meniscus, in gymnastics. I know, and I used to do those too a lot. The problem is as we age, most of us who have a tear in the meniscus also have arthritis. And it was discovered a couple decades ago that doing arthroscopy on patients who already have to fix the meniscus, if a person already has arthritis, is not always successful. Sometimes, some of you might have had that experience, sometimes it might make it worse. So that's, I know, so very frustrating. So if the joint is very worn out, usually I'll tell patients, ignore the meniscus, it's part of the arthritis process. And then we start with what we said, conservative treatment. Arthroscopy typically is not something that I recommend, and most orthopedic surgeons don't recommend if there's a lot of arthritis. If I see a normal looking knee, no arthritis, regardless of the age, with a torn meniscus, then I'll say yes. Then you get a knee arthroscopy by one of my sports medicine partners. But the knee needs to look good without arthritis.
And the recovery period?
Much quicker. Oh yeah, much quicker. I mean, you have, after a couple of weeks, most patients are back doing whatever they want, if there's no arthritis in it.
I got a question for you.
Yes, right.
Not a real question.
Someone I know well.
I'm gonna brag a little about him instead. We've known, Jan and I have known him for 13 years. 13 years I had a hip replacement early in the morning, of course, and at noon, I was asked to take a walk at noon that day, and I did with a little guy behind me, holding everything was already involved. He says to me, "Sir, would you please slow down? You're going too fast." That's the first thing I have.
That sounds like me.
At 8:30 that night, Dr. Benoit comes by and checks me out, doing good. And he says, "Ray, And he knew what happened earlier at noon that day. He said, you know, Ray, he said, if I didn't have that drip with you, you know, that we have to have, he said, I'd send you home tonight. Literally, send you home tonight. Well, you know, I go home the next morning early. Then the first thing they do is they send somebody to the house to help you do some exercises and stuff. And a lady came and she left, and before she leaves, she says, well, I'm not coming back. She said, you need to see me. So after a week or two of some therapy, everything was fine. I can say today, after my hip replacement, I have never, ever had pain, even the day of the surgery. And 5 weeks later, I was back on the golf course playing golf. Fantastic doctor.
Thank you so much. Usually when I hear something like this, that's all right, I'll send you that box of chocolate. Thank you.
Dr. Benoit,
Yes.
over here.
Hello?
Yes, hi. I just have some questions about complications after surgeries, like blood clots, excessive inflammation, infection. And can you tell me some percentages of some of your patients that have any of these three problems?
So, yes, definitely can tell you about that. I can tell you statistics of mine and national statistics. So, like I said at the end of my presentation, the patient's health condition before the surgery is very important as far as minimizing the risk of complications. If we take them one by one, blood clots. Having lower extremity surgery, any surgery below the hip, below the waist, increases risk of having blood clots. So for us here, specifically knee and hip replacements are known to increase the risk of blood clots, which means having a clot in the leg, which is not that bad as long as that clot does not migrate up to a person's lungs, which is called the pulmonary embolus, which can cause shortness of breath, can kill someone. So what we do in order to prevent that or decrease the risk is there are multiple things you do. One is, as this gentleman was saying here, Ray, getting patients up right away. Okay, the earlier out of bed, the better it is. When I trained a long time ago, we used to keep patients in bed for 3 days. We had a catastrophic amount of blood clots. So we want patients up, it helps circulate. That's one. Two, we use a blood thinner. Okay? Aspirin is typically enough. Some patients need more. If a person has had blood clots before and is very sensitive to those, there are other drugs we can use that will create more thinning of the blood. But the downside of those is that they also create more bleeding potential. And then the other thing we do while a person is at the hospital, if they're in bed, is we'll use devices that help compress the veins and help circulate. So the risk of that, the risk of catastrophic blood clots, PE as we call it, going up to the lungs and killing someone, thankfully is very low. And we're talking less than 1 in 10,000. The risk of having a blood clot in the leg is in the area of 2 to 5%, even with all the measures that we said. So if someone, yeah, go ahead.
Well, I had an ACL repair when I was late 30s, so it's been like 40 years ago, so I'd be more at risk of a blood clot.
Did you have a blood clot then?
No.
So no, the risk will not be higher. So the risk is not very high. As far as infections, okay, infections I always think are definitely, if not the most catastrophic, one of those most catastrophic complications that can happen. Because if a person comes and wants a joint replacement, has been in pain for years, and makes the decision to let me do surgery on them and have replacement done, if an infection occurs, it's a disaster. The disaster, which means going back in to drain that abscess, sometimes having to remove the knee or the hip or the shoulder replacement, being on antibiotics intravenous for 6 weeks, then having another surgery. So when I tell patients, make sure you want that surgery, that you're ready and you've been hurt enough and you went through all the non-invasive treatments, I really mean it. And because when that happens, even if it's just, even this right now in my hands is 0.3%. It's not much, but if it happens to a person, it's 100% for that person. And it's devastating when that happens. So there are a lot of things that are done to minimize the risk of infections. Okay, so optimizing the patient. Okay, diabetics, we can't change the fact that we're diabetic, but we can optimize, we can improve the A1C, because this way we decrease the risk of infection. Weight, okay, someone who's suffering from obesity, we work with our obesity clinic to decrease the BMI of patients. We found out that if the BMI, the body mass index, is above 40, the risk of infection is much higher. So we put the cutoff at 40 and we try to be as strict as possible. Antibiotics are given around the surgery. Special dressings. Nowadays, when I was young, we used to remove the dressing every day to look at the incision. We never do that now. We put a dressing that stays on for 2 weeks. The first time it's removed, it's 2 weeks after. And this way we avoid opening the incision to air. So a lot of things are done. Sterility in the operating room, experience of the surgeon, being expeditious. If a surgeon will take 3, 4, 5 hours to a surgery that takes 15 minutes or 60 minutes, that's a problem. So we need to be efficient. Okay, and it's not only the surgeon, it's the whole team.
What about the excessive inflammation? I have friends who've had really swollen knees after for a long time.
So inflammation is a problem that some patients suffer more from, okay? Inflammatory diseases for one, like rheumatoid arthritis, lupus. Those patients have more inflammation and sometimes need to be on prednisone for treatment of that. So it's the inflammation, the issue is that you have more pain, it causes more pain and swelling, and it limits your range of motion. So physical therapy, ice, and sedative, you can take those, ibuprofen and others. Despite that, some people need more aggressive treatments, I said, injections or prednisone.
Thank you.
You're welcome.
Dr. Benoit, are you doing robotics? And with that said, what time is that saving you as a doctor? And what time of recovery is that saving for the patient and improved from opening up like you did great?
Very good question. So robotic surgery in orthopedics is called robotic assisted. So in some specialties, the surgeon literally sits in the corner of the room and has joysticks. No joke, it impresses me so much. But not us. In orthopedics, we like to be hands-on, and our devices are assisting us. So it's a big robot, it's a big piece of equipment that has an arm where we connect our tools to. So the robotic assistance in surgery, in orthopedic surgery, is mostly for joint replacement. I use it for sure. I use it for some knees, for some hips. Now I need to be honest, there's a learning curve to that, and at the beginning it makes the surgery a little longer. I've done so many now that it doesn't take me any longer or less to do the robotics or not. What it has been shown to achieve is it removes what we like to call as orthopedic surgeons outliers. So something that's not positioned perfectly well. There's a certain area where we can tolerate a few degrees here or there. Sounds crazy, but the robotics minimizes that. So we hope that in the future, by doing that, the implants will last longer, that patients will be more satisfied and might not have pain, but right now it doesn't seem to show that. So benefits of robotics versus non-robotics in knee replacements, not there. I still use it because I don't want to be the last one to use it, and it's not any worse than to not use it, okay? I use it for hip replacements now a lot. So the advantage in hip is there in terms of precision of the surgery. So if we want to avoid differences as compared to the other side, length or what we call offset, we do better with robotics. I was a little frustrated to find that out. I pushed back, but when I started using it, I said, I think it's true. You know, the robot helps me, and you know, it's like in a car, having curtains, having airbags. It's, you know, technology comes and we can't push it back. Very costly. Robotics is very costly, and at the hospitals and at the surgery center, we have robots for those of us surgeons who want to use it. Recuperation after robotics, same. Same, yeah. We call it multifactorial. Okay, so the anesthesiologist, what they do, given a nerve block, doing the surgery and doing the anesthesia as precisely and as efficiently as possible is important. Giving the right medication. We figured out that giving a large amount of morphine or other opiates by themselves is not great. It constipates patients. It gives you a headache. It gives me a headache anyway. So we do better if we combine multiple medications around surgery. There's gabapentin, there's oxycodone, there's NSAIDs, there's some Tylenol, even IV Tylenol. Various things can be done with nerve blocks, and they all add up together and have less side effects than to use just one of them. How many years? I've been doing robotics since it exists, since it came out with Stryker, which is 12 years ago. I started with the partial knee replacement, because that's fantastic for that. Then I started doing knee replacements with it a couple years later, and the hip I started 2 years ago. Because I thought it was still better than a robot myself.
I just want to actually do a little testimonial here, but 12 years ago, I saw Dr. Benoit and had my left knee done. Previous to that, I had seen doctors in California where I lived. We moved out here, I had seen doctors. Nobody wanted to do it. Because they kept telling me, wait, you don't want to do it this early. I won't tell you how old I am now, but I was 62 back then. But Dr. Benoit, when I went in to see him, I was on a cane because I was so afraid to go even up a curb, any little step. So I took a cane everywhere I went. And when I saw Dr. Benoit, and he did all his imaging and checked me out, he goes, you are definitely a candidate. So we did it. But I also want to tell you that when he came to see me in the hospital, he said, okay, my work is over. And it all went very successful. But now your work is just starting. And that's the thing I really want to mention today, because when I was going to therapy, my husband was taking me for a while, and there was another couple, and the husband was in therapy, and the wife was sitting out in the lobby with my husband, and she goes, when did your wife have surgery? Well, my husband had it about the same time. How come your wife is so much farther along? And my husband said, well, because every single day at home, she's doing all these exercises. She's got the ball on the wall going up and down. She's doing the stretches. If she's not here in therapy, she's doing it at home. So he was right when he said the hard work is on you now. And that's, I think, one of the most important parts, because I have a lot of friends who've also been to other doctors. They don't want to do the therapy. They give up. And then they continue to have a problem, or they get a new problem. So don't forget that that's the hard part, and that's your part. And I will say this too. I did talk to Dr. Benoit because I really didn't want to go to Banner Physical Therapy. Nothing personal, but I had been there before for some other things, and I wasn't real satisfied. So I sought out a sports clinic that does sports therapy. And they would push me a little bit, and he cautioned me a little bit. But we all worked together, and I was doing everything I wanted to do. Tennis, swimming, walking, hiking, went to Italy, toured. So, can't complain.
Thank you so much. Thanks for sharing that. It's very rewarding. I tell you, I said at the beginning, I have a daughter who is in medical school, and that's exactly what I will share with her tonight when I talk with her. because it's, there's nothing better than to do work and see that patients or people moving on with their life. And thank you. Thank you so much. And you're correct. The physical therapy part is extremely important.
Before and after, I'm guessing.
Yeah.
So that was awesome. Thank you. We all came away with some important lessons. For you, if it's not your size, I can exchange it. But yeah, some Sun Health swag.
Wonderful.
Yeah. So I want to close with a couple of requests. One, if you could fill out the little survey form there, particularly if there's an area that you want to hear more about, doctors you want to hear from, particular interests you have that we can bring to our Coffee Connections for next year. We're doing a lot of planning right now, so that would be helpful. Second, really important request. My team gets evaluated on how many people come to these events. I know. So if you came in the back door and didn't sign in, I'm asking that you go over and make sure your name is checked off. It won't affect anything we do in terms of sending you or spamming you, but we'd love to have that. And the last and most important request is I would love for you to learn more about the Sun Health Foundation. I don't know if you got our annual report. I know the Landscroners are big supporters of ours, as are many of you. But we do a lot of work in the community, not just around healthcare, but around scholarships for healthcare workers, supporting people who have diabetes through Mountain Park Healthcare. So there's a lot of work we're doing, and we would love to have you partner with us on that. And with that, I want to thank you for coming today and thank Dr. Benoit for giving us such great information.